This is a YouTube short regarding secondary glaucoma. Before I start to go into the details of secondary glaucoma, I'll be following Kansky for secondary glaucomas because it is inadequately written in persons. To begin with the classification of secondary glaucomas, it can be pseudo-exfoliative syndrome, pigmentary glaucoma, neovascular glaucoma, malignant glaucoma, drug-induced inflammatory causes, and lens-induced. Coming to the easiest parts first, due to any kind of inflammation, there can be glaucoma. Lens-induced will consist of phacomorphic, phacolytic, and phacotopic glaucoma. The three most important topics being pseudo-exfoliative syndrome, pigmentary glaucoma, and neovascular glaucoma. We have to differentiate between PXF and pigmentary glaucoma. Pigmentary glaucoma is a form of open-angle glaucoma. It has a triad of Krukenberg spindle, iris transillumination defects, and Sampolisi line. Sampolisi line is common with pseudo-exfoliative syndrome. Pigmentary has the word men, so it is common in men. Which men? Myopic men. It is autosomal dominant in nature. Pseudo-exfoliative syndrome, exfoliation from any part, maybe anterior capsule of the lens or any part of the body which gets deposited in the trabecular meshwork and leads to its blockage. The exfoliative material is definitely fibrillin in nature and it is deposited in corneal endothelium or anterior capsule of the lens, known as the target sign, which is an important question. What are the side effects of having a cataractous lens with pseudo-exfoliative syndrome? There will be poor dilatation of pupil. You need to have iris hooks, BHEX rings at your disposal while operating. Capsular tension rings are to be used while operating on a cataractous lens with PXF. The zonules are weak, so chances of subluxation are very high. Again, there is presence of Sampollisis line, S for S. Sampollisis line is seen in Schwalbe's line, which is seen on gonioscopy, deposition of the exfoliative material on Schwalbe's line seen on gonioscopy. Coming to neovascular glaucoma, it is due to neovascularization of iris. Neo vessels. New vessels are never normal, they are abnormal and fragile. Causes, we have all heard about the Vedas. So we'll make a mnemonic VEDS. Vascular causes like CRVO, diabetic retinopathy, BRVO, ITBRVO, STBRVO, any vascular cause, vasculitis, Eales disease, diabetic retinopathy, sickle cell retinopathy, also known as 100-day glaucoma seen after CRVO. Pathophysiology being ischemia of the retina, leading whenever there is ischemia, as we have studied in Robbins pathology, whenever there is ischemia, there will be release of vascular endothelial growth factor, which will lead to the formation of new vessels, and these new vessels will traverse from the posterior chamber to the anterior chamber and lead to NVI, neovascularization of iris, neovascularization of the angle. Treatment will be intravitreal injection of anti-VEGF, panretinal photocoagulation, set-on operation, that is the glaucoma drainage devices we can use. In refractory cases, we can go for cryophotocoagulation. Malignant glaucoma, also known as ciliary block glaucoma or aqueous misdirection syndrome. Misdirection. Generally, aqueous flows from the posterior chamber to the anterior chamber and is drained through the episcleral channels. But in this case, there is misdirection. The aqueous will flow from anterior chamber to the posterior chamber due to the bowing of ciliary body anteriorly, which leads to a ciliary block and leading to aqueous misdirection. Most commonly seen in people who suffered from angle closure glaucoma and have been operated with trabeculectomy, post-trabeculectomy patients. This blocks the aqueous humor flow, which is misdirected to the vitreous, which increases the vitreous volume, increases the vitreous pressure, and pushes the lens forward. Lens diaphragm is pushed forward. Clinical features will include a shallow AC, negative Seidels test. I need not explain about the Seidels test. You use a fluorescent strip to check the dripping of aqueous from the anterior chamber. There is a rise in IOP and the drug of choice is atropine 1%. 1% atropine. Drug induced glaucoma will include. Point to be noted, topical steroids lead to glaucoma, systemic steroids lead to posterior subcapsular cataract. A very important question, a drug causing angle closure glaucoma, anti-epileptic drug, topiramate. Thank you.